Wound classification. Definition/introduction. The definition of a wound is damage to the integrity of biological tissue, including skin, mucous membranes, and organ tissues. Various types of trauma can cause these, and it is critical to ensure wounds are cleaned and appropriately dressed to limit the spread of infection and further injury. 2. To correctly classify the cleanliness and condition of wounds, the CDC has established classification definitions composed of 4 classes of wound statuses. Class 1 wounds are considered to be clean. They are uninfected, no inflammation is present, and are primarily closed. If the draining of these wounds is necessary, a closed draining method is necessary. Additionally, these wounds do not enter respiratory, alimentary, genital, or urinary tracts. Class 2 wounds are considered to be clean contaminated. These wounds lack unusual contamination. Class 2 wounds enter the respiratory, alimentary, genital, or urinary tracts. However, these wounds have entered these tracts under controlled conditions. Class 3 wounds are considered to be contaminated. These are fresh, open wounds that can result from insult to sterile techniques or leakage from the gastrointestinal tract into the wound. Additionally, incisions made that result in acute or lack of purulent inflammation are considered Class 3 wounds. Class 4 wounds are considered to be dirty infected. These wounds typically result from improperly cared for traumatic wounds. Class 4 wounds demonstrate devitalized tissue, and they most commonly result from microorganisms present in perforated viscera or the operative field. 3. Go to issues of concern. The main issue of concern with the wound classification scheme is that it has low inter-rater reliability among healthcare providers. 4. Additionally, this wound classification scheme has been shown to not work as effectively in neonatal surgical wounds. A different wound classification scheme may be necessary for this demographic. 5. The American College of Clinical Wound Specialists, ACCWS, emphasizes how difficult it is to find a common wound denomination. Each tissue that has to heal or the cause that induces the wound will necessarily have a different iter, a different approach. To give some examples, the peritoneal cavity or the intrauterine space have membranes with a substantial repair capacity, but the percentage of producing adhesions or fibrosis is high. The reparative processes will depend heavily on genetic, molecular, and immune factors. The same surgical approach may give different results: laparoscopy, hysterectomy, laparotomy. The American Burn Association, ABA, points out that, despite advances in patient care and survival, there are still difficulties in administering the most appropriate treatments, depending on the global geographic area. Furthermore, not only biological factors but also psychological ones merit consideration. According to the statistical research of 2020, abdominal wounds are most likely to be incorrectly classified as clean wounds, delaying the patient's recovery. Muscle injuries will respond differently depending on the cause: traumatic causes of sports activities or traumatic causes of war. Or, when the loss of muscle volume is significant, the metabolic environment will create antireparative molecular responses, lower amount of IGF-1 and profibrotic activity. Go to clinical significance. The clinical significance of proper wound classification lies in its ability to help predict the likelihood of surgical site infections, postoperative complications, and reoperation. 6. Correctly classified wounds also can potentially aid in assessing morbidity, mortality, and quality of life. 7. Patients receiving grafts also benefit from this classification scheme, as it helps to evaluate the degree of bacterial contamination upon grafting and, by extension, the ability of the graft to heal correctly. 8. The human body is not sterile. The infection results from dynamic interactions between a host, a potential pathogen, and the environment. It occurs when the microorganism successfully manages to evade the host's defense strategies, causing harmful changes in the host itself. The development of an infection is preceded by a series of complex interactions not yet fully known. The development of an infected wound depends on the pathogenicity and virulence of the microorganism and the immunocompetence of the host. The host/pathogen interaction does not always translate into a pathological form, and it is necessary to introduce new terms and definitions. Microbiological assessment by itself is not a reliable method for diagnosing an infected lesion, but a comprehensive, holistic patient assessment is also required. The wounds do not all have the same conditions, therefore, different wounds support different communities of microorganisms. The acquisition of microbial species by wounds can result in three distinct consequences: contamination, colonization, and infection. Colonization is not always synonymous with infection. Surgical wound infection control began in the 1960s in the United States with the classification of wounds into 4 categories: clean, contaminated, and dirty or infected, and with surveillance reports from Cruz and Ford. Subsequently, the Centers for Disease Control and Prevention, CDC, formulated definitions for the various hospital infections, further modified in 1992 when surgical wound infections became known as site infections. Subjective definitions of infected wounds led to the development of 2 wound classification systems, the Asepsis and the Southampton Wound Assessment Scale. Numerous tools based on different combinations of infection indicators have undergone development for open wounds. Some criteria for recognizing infected wounds include the presence of abscess, cellulitis, or the presence of secretions, serous exudate accompanied by inflammation, purulent serum, purulent blood, and pus. Additional suggested criteria include delayed healing, discoloration, a friable granulation tissue with ease to bleed, unexpected pain and/or irritation, pocketing at the wound's base, bridging of the epithelium or soft tissues, abnormal smell, wound degeneration. Go to nursing, allied health, and interprofessional team interventions. Research has determined that to accurately document a wound classification, implementing a curriculum that prioritizes wound classifications can result in a statistically significant increase in the accurate documentation of wound classifications. 9. Level 1. A factor often overlooked is the patient's nutritional approach to improve the wound healing response. For example, a diabetic ulcer will need a careful food assessment and accompanying dietary changes not to make the wound worse and allow healing. Further, malnutrition does not lend itself to correct tissue repair. Some food supplements can help heal a wound, for example, arginine helps collagen storage, or glutamine helps the immune system. Generally, the clinician assesses the wound, the nurse provides ongoing wound care and monitoring, and other healthcare personnel is involved in the patient's healing process. The presence of the psychologist can help with the possible emotional traumatic implications, the physiotherapist to improve or speed up the recovery processes of the patient's autonomy or to use tools, from electrostimulation to sensory stimulation, etc., or exercises. The pharmacist with medication reconciliation and providing antibiogram information for infection treatment or prophylaxis. These are all options in the interprofessional team approach to wound care. Go to nursing, allied health, and interprofessional team monitoring. It is critical that healthcare teams accurately classify wounds and manage wounds appropriately to optimize patient-centered care and quality of life while minimizing infection and further wound trauma. 10. Surgical wound classification and surgical site infections in the orthopedic patient. Abstract. Introduction. The Centers for Disease Control and Prevention created a surgical wound classification system, SWC, I, clean, 2, clean/contaminated, 3, contaminated, and 4, dirty, to preemptively identify patients at risk of surgical site infection, SSI. The validity of this system is yet to be demonstrated in orthopedic surgery. We hypothesize a poor association between the SWC and the rate of subsequent SSI in orthopedic trauma cases. Methods: 956 orthopedic cases were reviewed. Wounds were risk stratified interoperatively using the SWC grades, 1 to 4. SSI was diagnosed clinically or with objective markers. The SWC was compared with SSI rates using a Fisher exact test. Significance was set at p less than 0.05. Results: 400 patients met the selection criteria. The rate of infection was not significantly different across the SWC grades, p equals 0.270. There was a significantly higher risk of SSI among patients with diabetes, p equals 0.028. Conclusions: the Centers for Disease Control and Prevention SWC showed poor utility in predicting and risk stratifying postoperative SSIs in orthopedic surgical cases. Surgical site infection, SSI, is a dreaded complication of surgery, and the ability to identify risk factors for patients can be beneficial for managing patient expectations as well as optimizing good clinical outcomes. The National Nosocomial Infection Surveillance (NNIS) system set by the Centers for Disease Control and Prevention (CDC) ranked SSI third among all reported cases of inpatient nosocomial infections. Specifically, SSIs accounted for up to 16% of nosocomial infections in all hospitalized patients and 38% of all surgical patients. 1. SSIs remain a problem in surgery, despite significant advances in surgical techniques, modern technologies in the operating room, and preemptive measures such as perioperative intravenous antibiotics and preoperative skin antisepsis. SSIs will increase a patient's risk of morbidity and mortality and can have serious economic consequences. 2. 3. For estimates of the annual incidence of SSIs following all orthopedic procedures are between 31,000 and 35,000. 5. Active measures to identify important risk factors for developing SSI and preventing its sequelae led the CDC to create a risk model that includes the American Society of Anesthesiology (ASA) score, procedure duration, and a surgical wound classification (SWC). The SWC is categorized by the degree of gross contamination: clean, clean contaminated, contaminated, and dirty, and is used in conjunction with the ASA and procedure duration to identify those at risk of SSI. 6. The original classification system was developed by the National Academy of Sciences and the National Research Council Cooperative Research Study in 1964, with later modifications by the CDC in 1982. This classification system has been widely used, and although less prevalent as of recent, it is still being implemented at a number of institutions for hospital quality improvement measures, third-party payers, and quality improvement collaborators. 7. In the operating room, the surgical wounds are described as clean, clean contaminated, contaminated, and dirty. Table 1.1. The SWC is based on crude analysis by the observer and is one of the three equally weighted components in the risk model. SSI has not been exclusively studied in the orthopedic population using this classification system. The SWC has demonstrated efficacy for predicting SSI in visceral tissue. 7. However, it has also been described as ineffective because of low interobserver reliability between healthcare providers and institutions. 8. To our knowledge, there are no studies in the orthopedic literature that have evaluated the prognostic utility of the CDC SWC system for orthopedic SSI. Given its consistent use in select institutions to risk stratify patients at risk of SSI, our objective was to determine the prognostic value of the CDC SWC in the orthopedic patient. This study was performed at a Level 1 trauma center, where the CDC SWC is implemented for all surgical procedures. Wounds may be classified by several methods: their etiology, location, type of injury or presenting symptoms, wound depth and tissue loss or clinical appearance of the wound. Separate grading tools exist for pressure ulcers, EPWAP, burns, rule of nines, diabetic foot ulcers, Wagner/San Antonio, and general wounds 1. General wounds are classified as being 1. Superficial, loss of epidermis only. Partial thickness, involve the epidermis and dermis. Full thickness, involve the dermis, subcutaneous fat and sometimes bone. The most common method for classification of a wound is identification of the predominant tissue types present at the wound bed, i.e. black, necrotic, and the respective amount of each expressed as a percentage. This classification method is very visual, supports good assessment and planning, and assists with continuous reassessment too. Methods: 956 consecutive orthopedic surgery cases, from the year 2012, were recorded by the senior author onto a Microsoft Excel spreadsheet. Each chart was manually reviewed and appraised for further evaluation based on the selection criteria. Following a chart review of each of the 956 cases, the eligible cases were then de-identified and organized into a custom-built Microsoft Access database to enable further analysis. The organized de-identified data, including relevant demographic information, perioperative data, SWC, ASA, and duration of surgical procedure, were included for further analysis. All procedures were performed by a single orthopedic surgeon, i.e., DS, the senior author, at a single Level 1 trauma center. At any one time, each procedure included an orthopedic surgery resident and/or orthopedic surgery trauma fellow, along with the supervising orthopedic attending surgeon. All cases were classified postoperatively using the CDC SWC, as defined in Table 1, by the treating attending surgeon and circulating nurse. The final class designation was a consensus agreement 100% of the time. Case inclusion criteria. All logged surgical cases during the study period, 2012. All cases had a minimum of 3-month follow-up for patients without implantable devices. All cases had a minimum of 12-month follow-up for patients with retained implantable devices. Case exclusion criteria. Elective arthroplasty. Patients younger than 18 years. Procedures that were not considered index, i.e., revision surgery, removal of implant, or irrigation and debridement. Patients without a surgical incision as part of their procedure, closed reduction and manipulation. Collected data included demographics, age, sex, and body mass index, payer source, Medicare/Medicaid, private and uninsured, injury type, closed versus open, mechanism of injury, Table 2, extremity, upper, lower, or pelvis, estimated blood loss, duration of surgery, orthopedic devices, metallic and non-metallic implants, external fixators, skeletal traction pins, and antibiotic bead chains, and the presence of tobacco use and/or diabetes. Orthopedic procedures were derived from the operative report and evaluated based on the specific diagnosis documented by the surgeon under the pre- and post-operative diagnosis section to ascertain index or revision procedures. Laboratory data on elevated white blood count, C-reactive protein level, and erythrocyte sedimentation rate were recorded for only those patients who were suspected of having an SSI. Eligible cases were reviewed for postoperative occurrence of SSI as defined by the CDC National Healthcare Safety Network, CDC/NHSN. Point 4. Each patient's chart with respect to procedures was further evaluated for subsequent emergency department visits, readmission, antibiotic use, clinic visits suggesting SSI, and reoperations following the index procedure to rule out SSI, all within 12 months following the index procedure. Emergency department diagnosis, clinic diagnosis, or admission for infection/contamination of the surgical wound or area of previous incision was recorded as an SSI. Infections were stratified as superficial, deep, or organ space, Table 3.3. SSI was defined as infection up to 30 days postoperatively in cases without indwelling surgical implants, and up to 12 months in cases with retained implants. Moreover, all cases were evaluated up to 12 months following surgery regardless of the implant status. Of note, wires and external fixators, which are not otherwise specified in the original definitions of the SWC, were categorized as Class II, clean contaminated, because of their direct communication with the external environment. Statistical analysis. The SWC was compared with SSI rates using a Fisher exact test. Other predictors were tested for associations with SSIs using a Fisher exact test for categorical variables, and univariate generalized linear regression models were used for continuous variables. Logistic regression models were used to calculate adjusted odds ratios, ORs, and 95% confidence intervals, CICE. P-values less than 0.05 were considered statistically significant. All statistical analyses were performed using SAS version 9.4, SAS Institute. Go to Results. 956 consecutively logged orthopedic procedures were manually reviewed from the medical records, and 400 of 956, 42%, met the selection criteria, Figure 1.1. 27 cases of SSIs, 6.8%, were identified, as summarized in Table 4.4. The demographics of the SSI cohort are as follows: lower extremity external fixators, 40.7%, open reduction internal fixation, ORIF, of the lower extremity, 14.8%, ORIF of pelvis/sacrum, 11.1%, ORIF of upper extremity, 7.4%, closed reduction and pinning of lower extremity, 3.7%, ankle fusion, 3.7%, pelvic external fixator, 3.7%, upper extremity, closed reduction and percutaneous fixation, 3.7%, patelectomy, 3.7%, and nailing of intertrochanteric fracture, 3.7%. The location of the SSI cases was stratified as deep, N equals 14, 51.9%, superficial, N equals 12, 44.4%, or unknown, N equals 1, 3.7%. Table 3.3. There was no significant difference in the rate of infection across the SWC classes, P equals 0.27, Figure 2.2. When classes 3, contaminated, and 4, dirty, were combined and compared separately against class I, clean, and class 2, clean/contaminated, there was no significant difference, P equals 0.15. Likewise, when combined classes I/2, 4.5% or 18 SSIs/299 cases, were compared with combined classes 3/4, 8.9% or 9 SSIs/101 cases, there was no significant difference between the two combined groups, P equals 0.32. Patient demographics were stratified by SSI, Table 4.4. The CDC SWC showed no association with the rate of SSI, Figure 3.3. In addition, a regression analysis of all three variables among SSI cases, such as ASA score, procedure duration, and SWC, did not show a statistically significant association with the SSI rate, P equals 0.95, P equals 0.78, and P equals 0.28, respectively. Patients with diabetes were at a significantly higher risk of developing SSI, P equals 0.028. Of note, surgeries that resulted in an SSI and were performed on patients with diabetes were always of closed fracture type involving the lower extremities. The unadjusted OR of SSI among patients with diabetes was 2.85, 95% CI, 1.08 to 7.54, P equals 0.035, when adjusted for age, the odds for developing SSI remained relatively high but was not statistically significant, or 95% CI, 2.76, 0.99 to 7.69, p equals 0.052. Those with lower extremity injuries were at a significantly higher risk of developing SSI, p equals 0.0038, figure 4.4. The presence of SSI was significantly associated with a positive bone/tissue culture, p less than 0.0001. Among those with SSI, rates of elevated C-reactive protein level, erythrocyte sedimentation rate, and white blood cell count were 15%, 56%, and 48%, respectively. Patients in need of bone graft, i.e., fractures with marked comminution, segmental bone loss, or non-union following closed fracture treatment, had a higher incidence of SSI. This difference, however, was not statistically significant, p equals 0.085. Similarly, patients who were uninsured or had Medicaid/Medicare had a much higher rate of SSI compared with privately insured patients, 8.6% and 9.4% versus 2.8%, respectively. However, this was not statistically significant, p equals 0.055. When private patients were exclusively compared with Medicaid/Medicare and uninsured patients, there was a significantly lower rate of SSI seen in the private group, 2.8% versus 9.0%, p equals 0.021. Polytrauma patients, including those with spine, intracranial, intraabdominal, urological, and intrathoracic injuries, did not have a significantly higher incidence of SSI. The sample studied had 37/400, 9.3%, polytrauma patients, and of those, only 1/27, 3.7%, developed an orthopedic procedure-related SSI. Among patients who met the selection criteria, 400 of 956, the median number of index surgeries performed on a daily basis was 2, range 1 to 9. The average daily rate of SSI among index procedures was 0.18, with most SSIs occurring on days when multiple procedures were performed. Discussion. The SWC was designed as a component of the NNIS Risk Index to risk stratify wounds based on a crude assessment of the degree of contamination. It is used along with the procedure duration and ASA score and could provide prognostic information on likelihood for SSI. However, the current data did not show an association, i.e., direct relationship, of subsequent SSI and SWC grades, 1 to 4. This finding is in accordance with the poor concordance already seen in the general surgery literature evaluating the utility of the SWC. Ortega et al. 7 showed significantly lower rates of SSIs in the contaminated and dirty groups, classes 3 and 4, respectively, compared with the historically reported rates. A recent multi-center study of 11 participating institutions reviewed 2,034 cases and showed a classification discordance of 44% across the participating institutions. 0.8. The implementation of the SWC was part of a national effort to reduce SSI rates and to standardize reporting of these complications for quality improvement across institutions. Although the SWC is one of the three parameters, ASA and procedure duration being the other two, in the proposed risk model, it is the least objective and the one with wide inter-observer variability. Moreover, if found efficacious with some modifications provided by the results seen in this study, insurance status, lower extremity injuries, and history of diabetes mellitus, it has the potential to influence treatment strategies and perioperative protocols, inform surveillance protocols, and manage expectations, ultimately improving patient outcomes. We suggest that the initiative for quality improvement, SSI risk surveillance, and promoting standardized institutional reporting of such events is important. The current study provides some objective insights that may be useful for future modifications of the current SWC and how it may apply to the orthopedic patient. Some strengths of the current study are as follows: a retrospective design reviewing a single center and use of case logs of a single surgeon, which enabled consistent reporting of the SWC, thus avoiding the interobserver variability seen in previous SWC studies. 9 Despite previously published results on the SWC, there are still hospital systems remaining that rely on the aforementioned risk model to risk stratify patients, and may imply prognostic utility for subsequent SSIs, perhaps not its original intended use. Consequently, newer and more robust SSI risk models are being developed, that is, the NHSN procedure-specific risk index models. 8. 10 These newer models are yet to be adopted widely among hospital systems and may improve nationwide reporting, standardize the analysis of SSI and at-risk patients, improve infection control initiatives, and promote the development of novel strategies to reduce SSI risk. The patients evaluated in the study belonged exclusively to the adult population, age greater than or equal to 18 years, and largely included patients with orthopedic trauma injuries. This represents a different demographic from the pediatric and general surgery literature studied by Levy et al. 9 The results of this study can be particularly relevant to the general orthopedic surgeon, orthopedic traumatologist, hospital systems, and third-party payers, including Medicare/Medicaid, who value the SWC as part of their quality improvement initiative. The current study includes a wide spectrum of orthopedic procedures involving all four extremities, long bones, shoulders, knees, ankles, and wrists, and the pelvis. A possible explanation as to why the current results did not show an association, direct or indirect, between the SSI rate/incidence and SWC grade might be due to current operating room standards, surgical techniques, perioperative wound protocols, improved efficacy of antibiotics, and active surveillance of high-risk patients, i.e., open injuries. However, the variables that demonstrated significance or were positive prognostic indicators for postoperative SSI, diabetes mellitus, lower extremity injury, and payer source may strengthen future models. Historically, diabetes mellitus is known to be associated with a higher risk of SSI and was found to be a significant risk factor for SSI in the current study. A univariate analysis following spine procedures by Olson et al. 14 demonstrated that serum glucose levels preoperatively and within 5 days following surgery were significantly higher in patients in whom SSI developed than in uninfected patients. Specifically, patients with a preoperative serum glucose greater than 125 mg per deciliter or a postoperative serum glucose of greater than 200 mg per deciliter had an OR of 3.4 for developing a subsequent SSI. 14 This is consistent with our finding of an OR of 2.85 for patients with diabetes. Similarly, a study looking at postoperative infection rates in foot and ankle surgery among patients with and without diabetes showed that the presence of complicated diabetes increases the risk of postoperative infection by 10 and 6-fold compared with uncomplicated diabetes. 15. The Lower Extremity Assessment Project, LEAP, study, a large prospective series evaluating lower extremity injuries, demonstrated that patients with lower extremity trauma are confronted with higher rates of wound infections and osteomyelitis compared with the pelvic/sacrum or upper extremities. 16 Our data endorse this trend as lower extremity injuries accounted for a significantly larger proportion of resultant SSIs, 10.2% infection rate among lower extremity surgical procedures, and 1.9% among upper extremity procedures. Among all SSI cases, 74.1% were from the lower extremity. Another interesting finding was that the payer source proved to be a significant prognostic factor for SSIs when Medicaid/Medicare and uninsured patients were compared with privately insured patients, 9% versus 2.8%, p equals 0.021. In addition, our findings are consistent with those from a separate study looking at patients who had undergone primary hip or knee arthroplasty. Variables compared were complications, costs, and length of hospital stay for patients with Medicaid versus patients with non-Medicaid insurance. 17 The patients with Medicaid were found to have a higher prevalence of postoperative SSI than those with non-Medicaid insurance, or equals 1.7, 95% CI equals 1.3 to 2.1. 17 Reasons for this are likely multifactorial and may necessitate further investigation to better understand any differences that predispose or protect against SSI. Limitations to this study include a relatively small sample size, 400 cases, eligible for further analyses. A larger sample size might have been possible with a multicenter approach, but such a study design did not allow for control of potential interobserver variability, which has been described by previous reports. All wounds were appraised by a single trauma/general orthopedic surgeon and a circulating nurse, and a consensus was reached 100% of the time. Another limitation is that the study cohort does contain polytrauma patients with both orthopedic and non-orthopedic injuries. In these patients, confounding variables such as systemic inflammatory response syndrome, septicemia, and secondary procedures performed by other surgical services can influence the risk of SSI. Other variables not controlled for are as follows: type of implants used and miscellaneous host-dependent variables, postoperative patient compliance, wound surveillance, and acute rehab versus home care. Similarly, these variables may influence one's risk of SSI. 18. Unlike the Gustilo and Anderson wound classification system, in which open fractures are classified and further subdivided, Type I, Type II, Types IIIA, IIIB, and IIIC, with respect to the severity of soft tissue injury, the SWC fails to account for such intrinsic risk factors associated with SSI, that is, poor soft tissue coverage, need for soft tissue flap, or vascular repair. In addition, the former classification shows a positive correlation with postoperative wound complications, wound infection, osteomyelitis, and amputation, and a higher classification grade. 19. In conclusion, the CDC SWC system did not show an association with the rate of SSI. As used by some facilities, it was not an effective prognostic indicator for SSIs in the orthopedic patient. Certain variables were found to be positive prognostic indicators for future SSI and may be worthy of inclusion in future risk stratifying models. These variables include but are not limited to diabetes mellitus and lower extremity injuries. Table 1. Surgical site infection criteria. Criterion: surgical site infection, SSI. Superficial incisional SSI. Must meet the following criteria. Date of event occurs within 30 days following the NHSN operative procedure, where day 1 equals the procedure date, and involves only skin and subcutaneous tissue of the incision, and patient has at least one of the following: A. Purulent drainage from the superficial incision. B. Organisms identified from an aseptically obtained specimen from the superficial incision or subcutaneous tissue by a culture or non-culture-based microbiologic testing method which is performed for purposes of clinical diagnosis or treatment, for example, not active surveillance culture/testing, ASC/AST. C. A superficial incision that is deliberately opened by a surgeon. Physician * or physician designee and culture or non-culture based. Testing of the superficial incision or subcutaneous tissue is not performed. And patient has at least one of the following signs or symptoms, localized pain or tenderness, localized swelling, erythema, or heat. D. Diagnosis of a superficial incisional SSI by a physician * or physician designee. * The term physician for the purpose of application of the NHSN SSI criteria may be interpreted to mean a surgeon, infectious disease physician, emergency physician, other physician on the case, or physician's designee, nurse. Practitioner or physician's assistant. January 2023 Procedure-Associated Module. SSI Events. 9 to 12. Superficial incisional SSI. Comments: there are two specific types of superficial incisional SSIs. 1. Superficial incisional primary, SIP, a superficial incisional SSI, that is, identified in the primary incision in a patient that has had an operation. With one or more incisions, for example, C-section incision or chest. Incision for CBGB. 2. Superficial incisional secondary, SIS, a superficial incisional SSI, that is, identified in the secondary incision in a patient that has had an operation with more than one incision, for example, donor site incision. For CBGB. Note: refer to SSI Event Reporting Instruction Number 7 for NHSN operative procedure categories with secondary incision sites available for SSI attribution. Reporting instructions. For superficial incisional SSI, the following do not qualify as criteria for meeting the NHSN definition of superficial incisional SSI. Diagnosis/treatment of cellulitis, redness/warmth/swelling, by itself, does not meet superficial incisional SSI criterion D. A stitch abscess alone, minimal inflammation and discharge, confined to the points of suture penetration. A localized stab wound or pin site infection, depending on the depth, these infections might be considered either a skin, or soft tissue, ST, infection. Note: for an NHSN operative procedure, a laparoscopic trocar site is considered a surgical incision and not a stab wound. If a surgeon uses a laparoscopic trocar site to place a drain at the end of a procedure, this is considered a surgical incision. January 2023 Procedure-Associated Module. SSI Events. 9 to 13. Deep incisional SSI. Must meet the following criteria. Date of event occurs within 30 or 90 days following the NHSN operative procedure, where day 1 equals the procedure date according to the list in Table 2. And involves deep soft tissues of the incision, for example, facial and muscle layers. And patient has at least one of the following. A purulent drainage from the deep incision. B. A deep incision that is deliberately opened or aspirated by a surgeon. Physician asterisk or physician designee or spontaneously dehisces. And organisms identified from the deep soft tissues of the incision by a culture or non-culture based microbiologic testing method which is performed for purposes of clinical diagnosis or treatment, for example, not active surveillance culture/testing, ASC/AST, or culture or non-culture based microbiologic testing method is not performed. A culture or non-culture based test from the deep soft tissues of the incision that has a negative finding does not meet this criterion. And patient has at least one of the following signs or symptoms: fever greater than 38 degrees Celsius, localized pain or tenderness. C. An abscess or other evidence of infection involving the deep incision. Detected on gross anatomical exam, histopathologic exam, or imaging test. Asterisk the term physician for the purpose of application of the NHSN SSI criteria may be interpreted to mean a surgeon, infectious disease physician, emergency physician, other physician on the case, or physician's designee, nurse, practitioner or physician's assistant. January 2023 Procedure-Associated Module. SSI Events. 9 to 14. Comments: deep incisional SSI. There are two specific types of deep incisional SSIs. 1. Deep incisional primary, DIP, a deep incisional SSI that is identified in a primary incision in a patient that has had an operation with one or more incisions, for example, C-section incision or chest incision 4. CBGB. 2. Deep incisional secondary, DIS, a deep incisional SSI that is identified in the secondary incision in a patient that has had an operation with more than one incision, for example, donor site incision for CBGB. Note, refer to SSI Event Reporting Instruction Number 7 for NHSN operative procedure categories with secondary incision sites available for SSI attribution. Data analyses. Once procedure, denominator, and SSI, numerator, data are collected and entered into NHSN. The data can be analyzed/visualized in various ways, including with descriptive analysis reports and standardized infection ratio, SIR, reports. Types of SSI analyses reports. Descriptive analysis reports. Descriptive analysis report options, such as line listings, frequency tables, and bar and pie charts, are available for numerator and denominator data. A line list, frequency table, and rate table are also available to analyze pathogens and antimicrobial susceptibility data reported for each SSI. Quick reference guides on these reports can be found at the bottom of this page. https://www.cdc.gov/nhsn/ps-analysis-resources/reference-guides.html. SSI rate reports. SSI rates per 100 operative procedures are calculated by dividing the number of SSIs by the number of operative procedures and multiplying the results by 100. SSIs will be included in the numerator of a rate based on the date of procedure, not the date of event, DOE. Using the Advanced Analysis feature of the NHSN application, SSI rate calculations can be performed separately for the different types of operative procedures and stratified by the basic risk index. The universal exclusion criteria and SIR inclusion criteria do not apply in the calculation of the SSI rate. The SSI rate includes pathos events and outpatient procedures, but excludes procedures with non-primary closure techniques. More information regarding the basic risk index calculation can be found in the paper https://www.cdc.gov/nhsn/pdfs/datastat/2009 nhsnreport.pdf. SSI/SIR reports. The SIR is calculated by dividing the number of observed infections by the number of predicted infections. The SIR will be calculated only if the number of predicted HAIs, number pred in the NHSN application, is greater than or equal to 1 to help enforce a minimum precision criterion. SIR equals observed, O, HAIs. Predicted, P, HAIs. The number of predicted infections is calculated using SSI probabilities estimated from multivariate logistic regression models constructed from NHSN data during a baseline time period, which represents a standard population's SSI experience. The procedures/SSI occurring in adults are modeled separately from those occurring in pediatrics. January 2023 Procedure-Associated Module. SSI Events 9-28. The SSI/SIR can be generated for individual procedures for different summary time periods. While the SSI/SIR can be calculated for single procedure categories and for specific surgeons, the measure also allows you to summarize your data across multiple procedure categories while adjusting for differences in the estimated probability of infection among the patients included across the procedure categories. For example, you will be able to obtain one SSI/SIR adjusting for all procedures reported. Alternatively, you can obtain one SSI/SIR for all colo only within your facility. Additional notes about SSI/SIRs. 1. Closure technique. All the SSI/SIRs that use the 2006 to 2008 SSI baseline data will include only those procedures that were reported with a primary closure method. All the SSI/SIRs that use the 2015 baseline data will include all procedures that were reported with primary or non-primary closure methods. 2. Infection present at time of surgery, PATOS. A. All the SSI/SIR reports that use the 2006 to 2008 SSI baseline will include SSIs that are reported as present at time of surgery. This means that the PATOS event is included in the numerator of the SIR and the procedure from which the event occurred is included in the denominator of the SIR. B. All the SSI/SIR reports that use the new 2015 SSI baseline will exclude SSIs that are reported as present at time of surgery from the numerator and the procedures to which they are linked from the denominator. Therefore, the PATOS events and their linked procedures are not included in any of the 2015 baseline SSI/SIR reports. 3. SIRs based on procedure date. SSIs will be included in the numerator of an SIR based on the date of procedure, not the DOE. This is because the procedure carries the risk for the infection/SSI. There are 3 main SSI/SIR models available from NHSN, each briefly described in the table below. The first 2 models, the all SSI/SIR and the complex A/R SSI/SIR models, are available for all NHSN operative procedures/SSI occurring in both adults and pediatric patients, while the third model, the complex 30-day SSI/SIR, is available for colon and abdominal hysterectomy procedures/SSI occurring in adults only. Please see the NHSN SIR guide for more model-specific information. Table 5, Inclusion Criteria of SSI in SIR Models. All SSI/SIR model include separate models for inpatient and hospital outpatient procedures under the 2015 baseline. Include superficial, deep end organ/space SSIs. Superficial and deep incisional SSIs limited to primary incisional SSIs only. Includes SSIs identified on admission, readmission, and via post-discharge surveillance. Separate models for patient population. Pediatric data is separated from adult data. Complex A/R SSI model includes only deep incisional primary SSIs and organ/space SSIs. Includes only SSIs identified on admission/readmission to facility where procedure was performed. Includes only inpatient procedures. Used for the HAI Progress Report, published annually by CDC. Separate models for patient population. Pediatric data is separated from adult data. Complex 30-day SSI model used for CMS. IPPS includes only in-plan, inpatient colo, and HYST procedures in adult patients, specifically, greater than or equal to 18 years of age. Includes only deep incisional primary SSIs and organ/space SSIs within event date within 30 days of the procedure. Includes SSIs identified on admission, readmission, and via post-discharge surveillance. Uses diabetes, ASA score, gender, age, BMI, oncology hospital, and closure technique to determine risk for colo, under the 2015 baseline. BS2 uses diabetes, ASA score, age, BMI, and oncology hospital to determine risk for HYST under the 2015 baseline, BS2. Note, the complex 30-day SSI model under the 2006 to 2008 baseline. BS1 uses only age and ASA to determine risk for both COLO and HYST. BS1 applies to data up to 2016. Used only for CMS IPPS reporting and for public reporting on hospital. Compare. For more information on how to generate a line listing report to determine SSI inclusion criteria, please see the quick reference guide, https://www.cdc.gov/nhsn/pdfs/ps-analysis-resources/ssi-events-list-qrg.pdf. In addition to the SSI inclusion criteria listed above, there are a set of universal exclusion criteria that are applied to all procedures and associated events prior to the SIR calculation. Any procedure that meets any of the exclusion criteria is universally excluded from any SSI-SIR calculation. The line list of procedures excluded from the SIR is an NHSN analysis report that is intended to assist users in reviewing the procedures that are excluded from the SIRs and the reasons for the exclusion. Users can use the quick reference guide. January 2023 Procedure Associated Module. SSI Events 9 to 30. https://www.cdc.gov/nhsn/pdfs/ps-analysis-resources/line-list-excluded-sir.pdf2. Generate and interpret this report. This list of universal exclusion criteria, also called the universal exclusion criteria, applies to procedures regardless of the SSI model. Often, the reason for procedure exclusion from the SIRs is due to data quality issues, which can be addressed, if applicable. Table 6, Universal Exclusion Criteria for NHSN Operative Procedures. Universal Exclusion Criteria Variables Definition of variables. Exclamation bar IND. Procedure excluded for missing risk factors used in risk adjustment of applicable procedure category for SSI models. Exclamation bar list. List of missing risk factors used in risk adjustment of applicable procedure category for SSI models. Excluder threshold IND. Procedure excluded due to procedure duration being less than 5 minutes or exceeding the IQR5 value. Please see the list of procedure duration cutoff points in the SSI section of the SIR guide. https://www.cdc.gov/nhsn/pdfs/ps-analysis-resources/nhsn-sir-guide.pdf. Exclage GT 109 IND. Procedure excluded if the patient's age at time of procedure is 109 years or older. Excl outpatient IND. Procedure excluded because it was reported as an outpatient procedure. Note, all outpatient procedures are excluded from the inpatient SSI-SIRs. Calculated using the 2015 baseline. There are separate SIR reports for procedures performed in hospital. Outpatient procedure departments, HOPD. Exclped 30D. Procedures performed in pediatric patients are excluded from the complex 30-day model. Excl-gender off. Procedure excluded because patient's gender was not reported as male or female, specifically, gender equals other. Excl-invalid joint rep hemi. Procedure is excluded if procedure code is KPRO or HPRO and procedure Type is a hemi-joint replacement reported as a total revision or a total joint. Replacement reported as a partial revision, and procedure date is January 1, 2015, December 31, 2015. BMI threshold IND. Procedure excluded if the adult patient's BMI is less than 12 or greater than 60. In pediatric patients greater than 18 years if BMI is less than 10.49 or greater than 65.79***. https://www.cdc.gov/nhsn/pds-analysis-resources/reporting-heighten-weight-for-procedures-508.pdf. January 2023 Procedure Associated Module. SSI Events 9 to 31. This BMI exclusion applies to all procedures on pediatric patients, in both applicable SSI models, all SSI, and Complex A/R. CDC growth charts are used to assess BMI in pediatric patients, calculated using height, weight, age, and gender. More information can be found here. https://www.cdc.gov/nccdphp/dnpow/growthcharts/resources/sas.htm. NHSN Group Analysis. NHSN Group users can perform the same analysis as facility-level users in NHSN. A few helpful tools in NHSN for groups are listed in the resources below. These tools are guides on how to start and join a group, how to create a template to request data from facilities, how to determine the level of access granted by the facility following the previous steps, and how to analyze the facilated data. Appendix A. Specific event types available for SSI attribution by NHSN procedure category. Operative procedure category specific event type. AAA abdominal aortic aneurysm repair DIP deep incisional primary. ENDO endocarditis. GIT gastrointestinal tract. IAB intra-abdominal, not specified elsewhere. SIP superficial incisional primary. DASC arterial or venous infection. AMP limb amputation bone osteomyelitis. DIP deep incisional primary. JNT joint or bursa. SIP superficial incisional primary. APPY appendix surgery DIP deep incisional primary. GIT gastrointestinal tract. IAB intra-abdominal, not specified elsewhere. SIP superficial incisional primary. AVSD AV shunt for dialysis DIP deep incisional primary. SIP superficial incisional primary. DASC arterial or venous infection. Bili bile duct, liver, or pancreatic surgery DIP deep incisional primary. GIT gastrointestinal tract. IAB intra-abdominal, not specified elsewhere. SIP superficial incisional primary. BRST breast surgery BRST breast abscess or mastitis. DIP deep incisional primary. DIS deep incisional secondary. SIP superficial incisional primary. SIS superficial incisional secondary. CARD cardiac surgery bone osteomyelitis. CARD myocarditis or pericarditis. DIP deep incisional primary. ENDO endocarditis. IAB intra-abdominal, not specified elsewhere. Lung other infections of the lower respiratory tract. MED mediastinitis. SIP superficial incisional primary. DASC arterial or venous infection. Operative procedure category specific event type. CBGB coronary bypass with chest and donor incisions. Bone osteomyelitis. CARD myocarditis or pericarditis. DIP deep incisional primary. DIS deep incisional secondary. ENDO endocarditis. IAB intra-abdominal, not specified elsewhere. Lung other infections of the lower respiratory tract. MED mediastinitis. SIP superficial incisional primary. SIS superficial incisional secondary. DASC arterial or venous infection. CBGC coronary bypass graft with chest. Incision. Bone osteomyelitis. Card myocarditis or pericarditis. DIP deep incisional primary. ENDO endocarditis. IAB intra-abdominal, not specified elsewhere. Lung other infections of the lower respiratory tract. MED mediastinitis. SIP superficial incisional primary. DASC arterial or venous infection. CEA carotid endarterectomy DIP deep incisional primary. DIS deep incisional secondary. SIP superficial incisional primary. SIS superficial incisional secondary. DASC arterial or venous infection. Col gallbladder surgery DIP deep incisional primary. GIT gastrointestinal tract. IAB intra-abdominal, not specified elsewhere. SIP superficial incisional primary. Colon surgery DIP deep incisional primary. GIT gastrointestinal tract. IAB intra-abdominal, not specified elsewhere. OREP deep pelvic tissue infection or other infection. Of the male or female reproductive tract. SIP superficial incisional primary. USI urinary system infection. January 2023 procedure-associated module. SSI events. 9 to 35. Operative procedure category specific event type. CRAN craniotomy bone osteomyelitis. DIP deep incisional primary. IC intracranial infection. MEN meningitis or ventriculitis. Sinusitis. SIP superficial incisional primary. CSEC caesarean section DIP deep incisional primary. EMET endometritis. GIT gastrointestinal tract. IAB intra-abdominal, not specified elsewhere. OREP deep pelvic tissue infection or other infection. Of the male or female reproductive tract. SIP superficial incisional primary. USI urinary system infection. FUSN spinal fusion bone osteomyelitis. DIP deep incisional primary. DIS deep incisional secondary. Disc space infection. IAB intra-abdominal, not specified elsewhere. IC intracranial infection. Lung other infections of the lower respiratory tract. MEN meningitis or ventriculitis. SA spinal abscess/infection. SIP superficial incisional primary. SIS superficial incisional secondary. FX open reduction of fracture bone osteomyelitis. DIP deep incisional primary. JNT joint or bursa. SIP superficial incisional primary. GAST gastric surgery DIP deep incisional primary. GIT gastrointestinal tract. IAB intra-abdominal, not specified elsewhere. Lung other infections of the lower respiratory tract. SIP superficial incisional primary. Herniorrhaphy DIP deep incisional primary. IAB intra-abdominal, not specified elsewhere. SIP superficial incisional primary. January 2023 procedure-associated module. SSI events. 9 to 36. Operative procedure category specific event type. HPRO hip prosthesis bone osteomyelitis. DIP deep incisional primary. PJI periprosthetic joint infection. SIP superficial incisional primary. HTP heart transplant bone osteomyelitis. CARD myocarditis or pericarditis. DIP deep incisional primary. ENDO endocarditis. IAB intra-abdominal, not specified elsewhere. Lung other infections of the lower respiratory tract. MED mediastinitis. SIP superficial incisional primary. DASC arterial or venous infection. HYST abdominal hysterectomy DIP deep incisional primary. IAB intra-abdominal, not specified elsewhere. OREP deep pelvic tissue infection or other infection. Of the male or female reproductive tract. SIP superficial incisional primary. DCUF vaginal cuff infection. KPRO knee prosthesis bone osteomyelitis. DIP deep incisional primary. PJI periprosthetic joint infection. SIP superficial incisional primary. KTP kidney transplant DIP deep incisional primary. IAB intra-abdominal, not specified elsewhere. OREP deep pelvic tissue infection or other infection. Of the male or female reproductive tract. SIP superficial incisional primary. USI urinary system infection. DASC arterial or venous infection. LAM laminectomy bone osteomyelitis. DIP deep incisional primary. Disc space infection. IAB intra-abdominal, not specified elsewhere. IC intracranial infection. Meningitis or ventriculitis. SA spinal abscess/infection. SIP superficial incisional primary. Operative procedure category specific event type. LTP liver transplant DIP deep incisional primary. GIT gastrointestinal tract. IAB intra-abdominal, not specified elsewhere. SIP superficial incisional primary. DASC arterial or venous infection. Neck surgery DIP deep incisional primary. EAR ear mastoid infection. Oral cavity infection, mouth, tongue, or gums. SIP superficial incisional primary. UR upper respiratory tract infection, pharyngitis. Laryngitis, epiglottitis. NEPH kidney surgery DIP deep incisional primary. IAB intra-abdominal, not specified elsewhere. OREP deep pelvic tissue infection or other infection. Of the male or female reproductive tract. SIP superficial incisional primary. USI urinary system infection. OVRY ovarian surgery DIP deep incisional primary. IAB intra-abdominal, not specified elsewhere. OREP deep pelvic tissue infection or other infection. Of the male or female reproductive tract. SIP superficial incisional primary. USI urinary system infection. Pacemaker surgery CARD myocarditis or pericarditis. DIP deep incisional primary. ENDO endocarditis. IAB intra-abdominal, not specified elsewhere. SIP superficial incisional primary. DASC arterial or venous infection. PRST prostate surgery DIP deep incisional primary. IAB intra-abdominal, not specified elsewhere. OREP deep pelvic tissue infection or other infection. Of the male or female reproductive tract. SIP superficial incisional primary. USI urinary system infection.